All right. Hey guys. Hey guys. So it's Friday. I missed lesson of the day on Wednesday, and I would like to tell you what came up on Wednesday. So Wednesday, which is hump day, which is our consult day, I see a fair amount of consults, usually about like 50 people throughout the day. I think this week was 45, so nice and easy. And there were several lip patients that I saw. There were actually a couple others that I want to talk about, but there were several lip patients that I saw who came in asking about their lips, and they all kind of looked a little like that. So they would call it like a Marge Simpson lip or a simian lip or a monkey lip or things like that. And they were aware of it, and they just didn't know what was causing it because they'd only had filler one time. And they all had this hooded appearance on the side. So I want to go over lip anatomy. And most doctors don't even fully understand lip anatomy. It took me a while, and I've done tons of lips. So I'll explain what I've discovered and what I saw in these patients. So what I saw in these patients was mainly migration of filler, which is very common. We know it happens. And the reason this happens is because we fill the lip in one of three spots along the vermilion border. The upper portion here is called the vermilion border. There's the vermilion body, which is the dry vermilion, and then inside is the wet dry border, and then the wet vermilion, or the mucosa of the lip. So when we inject, we need to stick to this area, which is the dry vermilion. And if you go up next to the vermilion border, it immediately goes up into the philtrum. So we call that spread. So Dr. Harris calls that spread versus migration. And I just used to call it all migration, but it makes sense that it's spread because it just immediately goes from here to there. It hasn't migrated anywhere. It's where you injected it. You just didn't know you injected it. And it's because the lamina propria of the lip is attached to the SMAS of the philtrum. So it immediately goes there. Once it's there, it ends up staying there for years and years and years. Most of the fillers, like the newer High Cross or Vicross or all those things, like you'd say like Versa, Volbella, Volure, Restylane, Define, Refine, once they spread there, they stay there. They don't really move so much. The classic Juvederm and Juvederm XC are the ones that climb up about 10 millimeters or so, and they change the color. They change the color of the lip to this whitish color and up here to have a glare and a whitish color and a bulge. So that's what you see on most people. Then what I'm noticing is people try to lift the lip with fillers. So here's a good question. Can you lift the lip with fillers? The answer is yes and no. So here we have our nose and there we have our mouth. There are two parts of your lip. One of them is the subnasal lip. The other is the subfacial lip. And they're separated by a line that I designated the diagonal line in my Cupid lip. So that's why it's Cupid. It's CPID, center, paramedian, intermediate, diagonal. These are the relaxed skin tension lines. So the relaxed skin tension line that goes from the nose down to the lip is called the diagonal. Everything between here, which is typically where your white roll is of the lip, is the subnasal lip. Everything lateral to that is the subfacial lip, which means that it's hanging from your face. So the subnasal lip, where you see a firm vermilion or a white roll, is where, if you inject, you can get some eversion and actually lift the body upwards because it is suspended by the nose and it actually pulls out. The lateral portion here, which is the subfacial lip, ends up getting heavier over time when you inject it. So you can't lift it by injecting above it or injecting up here or doing anything else. So it is prone to failure. And this happens over and over again. And doctors have these doctors are very smart, but they're like really stupid because doctors, being so smart, have to be imaginative to try to progress their practices. Practice makes perfect, and medical practice takes art and science, and you have to think of all these things. But sometimes they go too far in their imagination and don't tie it to reality. And this is one of those situations where they imagine, I'm going to lift, I'm going to do this to lift you, I'm going to do this to lift you. And they have a concept like a person who's standing behind curtains, walking through the curtains, and as you push forward, you see more teeth, and that lifts you. And that's true, but that's only if you're pushing teeth forward, not if you keep lifting here. So when you inject around this area, you tend to make the lip heavier. So over here, laterally in the dry vermilion, what I tend to do is get more exposure but by just pushing the dry vermilion body out a little bit. And when the mouth is closed, you don't see it as much, but when the mouth is open a little bit, you see a little bit of increased sexiness. For the people who have a buried lateral lip, but central lip looks perfect, you don't really need to do a lip lift. You can do a corner lift, and a corner lift is easy. You follow that diagonal line, you excise skin that's over here that's not red, and you drag the red skin up to replace it. That's a corner lift. Easy as that. Very quick healing time, and really heals very, very well. So all these patients, oh, hi Liz, hi Sushi. So all these patients, I tell them who had the buried corner, which were a lot of them today or Wednesday, I say you need to dissolve the fillers and then let's do a corner lift. So in dissolving, I prepare them. I tell them, listen, when you dissolve your filler, if you're young and don't have that much filler in there, it actually deals with it, copes with it pretty well, where the lip doesn't collapse. But if you have a lot of filler in there, fillers cause this microcystic expansion inside the SMAS layer of the philtrum. And that stretches out the little areas, and when you go dissolve it, they all collapse. So your SMAS collapses in an exaggerated fashion, and it damages the SMAS, and it can be temporary, it can be permanent, and I'll tell you, very commonly, it's permanent. It just lasts a very long time. It's not hard to fix. All you got to do is go back and remind your body that there needs to be hydration in there. So you put some hyaluronic filler back in there, very, very small amount into this area, and it comes back. So I had another patient come in, and this is pretty awesome, which shows that patients are listening more than doctors, because doctors are stubborn assholes sometimes, and they don't listen, even if you have more experience and knowledge than them, and have shown that repeatedly. They stick to their guns, just like when, I always compare it to when H. pylori was discovered. Doctors denied it over and over again. There's no way bacteria can live in an acidic environment. There's no way. And then now it's common understanding, common knowledge that H. pylori, which is a bacteria, obviously can grow in the stomach, as many other bacteria can. So people will deny that hyaluronic acid dissolver, hyaluronidase, can damage your own tissue, or that it'll be permanent. And it's ignorant. It is purely ignorant, and it's fine. They'll come around sooner or later. They want the science. They want to see it on ultrasound. I'm not an ultrasound kind of guy. I'll leave that to the smarter guys to figure out and prove it. I don't need to prove it. But before, they didn't believe that hyaluronic acid filler could last 10 years, even though I lectured about it 7 years ago, telling everyone, no, it lasts 10 years. It can last 15 years. They thought it just goes away. Now it's common knowledge, commonly accepted. They didn't accept that it could migrate. Now it's commonly accepted that it can migrate. So for some reason, they didn't believe that it could last 10 years. Like, where's the science that it could last 10 years? Now they know it can last 10 years. But now I tell them it can damage you for 10 years. And now they're like, where's the science? How can it damage you for 10 years? So whatever. They'll get it sooner or later. But either way, I had a patient that came in. This is the point of it. And I was so happy she said this. She came in. She's never had dissolver, I don't think. But she said, isn't this SMAS deflation there? And she had this dark little mustache line that came across. And I said, yes, that is SMAS deflation. And it is SMAS deflation. If you go in and you put a dot of filler into that little dark mustache line, which has a depression, even the tiniest bit of filler, it ends up rehydrating, bringing in water, and it becomes bright and normal colored skin again. So there's a lot that goes into your skin color that people don't understand, because we're not, geniuses, all of us, and we don't see through skin, but there's a lot that goes into the color of it. And part of the color of the skin is contributed to by the hydration of the SMAS layer, which is the thickest layer in the lip other than the muscle. So if you have a deflated SMAS over here, you end up looking dark. If it's overinflated with hyaluronic acid, it looks white. If you have it just perfect, it looks skin colored, which has vascular blush in it like the rest of our skin does, because we're not dead and pale and we're not purple. It's oxygenated blood. So you end up getting like this normal rosy skin color. So that patient is said to have a little tiny touch of filler in there. You don't need to put much. And the other patients I saw are getting either lip lifts or corner lifts, or lip lift with corner lift. And that would be the lesson of the day, is please understand the anatomy. Subnasal lip, subfacial lip, SMAS layer, lamina propria, they're connected. Vermilion border, white roll, no vermilion, white roll. After that, that's your subfacial lip. Reacts very differently than the rest of the lip. And the muscle does not function on these patients either because the filler has migrated up and is on top of the orbicularis oris muscle. And orbicularis oris does not work well when it's overly hydrated. Doesn't work well either when it's dry. Doesn't work well either when the teeth push out too much. But that's another topic. So don't keep injecting over and over again. And every once in a while, get it checked out by somebody who knows what they're talking about and can actually see that. So go over a couple of questions. The best question just came by Jen Jevons. So can you fix mass deflation with a fat transfer? This was another topic I talked about today with patients. Fat transfer into the lip is unpredictable. There is no natural discrete fat layer that exists in the vermilion, nor is there one in the upper lip. The upper lip occasionally has a very thin palisading fat layer under the dermis. On most people, they have fat, microfat kind of dispersed within the SMAS, but there's no fat layer. It's a SMAS layer. So when people inject fat, it typically goes here, migrates up, and you get balls and lumps and bumps in there. You can do microfat and you can do nanofat, and they do different things. So if I ever inject fat into the lip, I break it down, and if it doesn't survive, I'm fine with that. It does make the skin look healthier and the lip look healthier either way. So I like using microfat where it's broken down. Otherwise, if you have a deflated SMAS, the coolest thing is you can get fat from your abdomen, fat ass abdomen, and you mix it with PRP, which is platelet-rich plasma from your blood, and you make this mix that I call FAT, platelet hybridized adipose therapy, which is nanofat with PRP. And if you inject that into the SMAS, very small amounts, I've seen this dozens of times now, and it's very, very cool. The SMAS reinflates itself. So you're not grafting the fat in there. You've stimulated the SMAS. This is my theory, but you stimulated the SMAS, and it ends up rehydrating and thickening again. The SMAS is a very interesting layer that exists throughout your whole face to different extents, thicker, thinner in some areas, and it is largely responsible for the hydrated appearance of your skin, of not the dermis, but the plumpness and the way that light reacts and reflects on it. So putting the nanofat PRP into the SMAS can rejuvenate it. What I typically do is mix that either with nanofat PRP and microneedling, or I do CO2 laser on there. So we'll see if there's any other questions. Mel, do you think it's possible to reject filler like a foreign object? Yes, that is possible. It is unlikely that you'd reject it like a foreign object because that would push it to the surface, but there are patients who have weird immune responses to them that people would think are infections, and they're not infections. Your immune system comes and fights it, and you know it's not an infection because it was a bilateral onset simultaneous, so both sides of the face it happens to at the same exact time and in a symmetric manner and in the same exact places. So it would be really weird for an infection to do that. Not impossible, but it's more likely in those cases that if it's happening at the same exact time, it was more likely some kind of immune system reaction. Autoimmune responses are classified as a type 5 allergy, so they are in the allergy category. If you look at the types of allergies, there used to be 4, there's 5 now, from last I checked from med school. So you can have a reaction to them, and if you're having a reaction to them, you got to figure out what to do. Are you going to dissolve these things? Are you going to use steroids? Are you going to take steroids? Or are you going to use IVIG? IVIG is a very cool thing. It's intravenous immunoglobulin. And the IVIG is cool because there's Dr. John Joseph, who talks about this a lot, with Bell's palsy patients. He's seen great success in using IVIG rather than just steroids, which means he thinks there's an immune reaction going on, and I think that's extremely likely. I haven't seen the evidence for it, but it makes a lot of sense. So yes, face can reject filler, but you don't typically see filler coming to the surface and spitting out type of rejection, but you do see reactivity, meaning the face gets puffier over time and can react to it that way. And certainly, just as we have foreign body responses in the rest of our body, if your face is responding to it and you have inflammation in the face, you can have inflammation in your entire body. We don't know if that happens to patients. It's very hard to analyze. It's very hard to study, but it's a possibility. And that's all. So other questions we got. My body metabolizes filler within a couple of months. That's not unusual. That's usual, but don't think that it all goes away. It doesn't. You still have residue that's in there, and your face starts to change its character. You don't notice it so much anymore. So, question from Dr. Ionage: if you inject microfat into the lips, do you have to dissolve the fillers first? Okay, so two things to think about. So let's say someone has fat injected in their lips already, and they have bumps and stuff from it, or silicone. You do not want to dissolve those patients. What's going to happen is you're going to dissolve their SMAS and their lamina propria. Their lamina propria is going to get shrunken, and they're going to look like a very dry, blistering lip. And up here, they're going to get deflated, and you're still going to be thick. And then you go in there to operate, and there's no SMAS left. It's all shrunken down. You have all this fat. So then you end up lifting their lip, and the skin bunches up onto itself. You have all these indents, very hard to fill afterwards. So that's just a cautionary tale for someone who does lip lifts. Now, if you're going to inject microfat into the lip, if it's overfilled, yes, you should dissolve it first. And I was asked this question the other day by a doctor I know. How do I use my dissolver? Do I dilute it? I always dilute it. You don't need much dissolver. People don't understand. You do not need much dissolver, and it's better to use smaller amounts and not damage your own tissue. So what I do is I grab a 1 cc syringe, 1 milliliter syringe. I put in 3 strengths. It's either going to be weak, medium, or strong. If it's weak, I put in 0.1 cc's of vitreous. Vitreous comes from like lamb nuts. So there's human, there's ovine, there's this, there's that. You can get different types of hyaluronidase, but I use vitreous. And you put 0.1 cc's of vitreous, 0.8 cc's of 1% lidocaine plain, and 0.1 cc of bicarbonate so it doesn't burn. That's weak. Strong is 0.2 cc's, and then, medium is 2.2, strong is 0.3 cc's. So I dissolve it with that first. I wait about 2 weeks, so meaning I do the dissolver at least 2 weeks prior to a surgery, because when you dissolve somebody, the majority of patients will rehydrate within about 3 weeks. The science of hyaluronic acid replenishing itself every 3 hours to 3 days is not related to what happens with hyaluronic acid gels and dissolver. Very, very different type of thing that's going on. But either way, it takes about 2-3 weeks for them to rehydrate, so I would wait for that to occur beforehand. And you can always mix with nanofat. And anytime you're injecting the lip, just realize it has a high chance of migrating north and causing lumps and bumps over there. So lots of other questions, but I think we will call it because it's Friday and we're going to Nobu with Dr. Gregor Bran, who's an awesome guy. All right, I will post this in the section. We have a section now that's going to happen for Lesson of the Day Wednesdays on a Friday.